Good afternoon, and thank you guys for joining us for the FDA QRC latest webinar. Today's topic is Assent and Consent in Clinical Research for Children and is presented by Eric Zierzo, MBA, and a project manager here at FDA QRC. Eric has more than 20 years experience working in clinical research, regulatory affairs, and quality assurance. He's worked as a research coordinator, research regulatory specialist, regulatory compliance manager, and research program manager. His regulatory and quality assurance experience includes conducting many internal, compliance, and investigative site audits. Eric began working with FDA QRC in July 2019 as a project manager after working as department administrator with one of the premier healthcare organizations in Cleveland, Ohio. Eric has served as a department representative for the IRB executive committees as well as the Center for Clinical Research, SOP, and Education committees. These committees were responsible for education, research, compliance, and governance of conducting clinical trials. He has conducted clinical trials and provided regulatory oversight in multiple therapeutic areas such as medical genetics, cardiovascular genetics, pediatrics, anesthesia, oncology, urology, nephrology, and dermatology. Eric was fortunate to have worked on two of Cleveland Clinic's largest groundbreaking clinical research studies that explored the genotypes that are responsible for premature coronary artery disease and heart attacks. These studies led to the discovery of the first confirmed gene that contributed to coronary artery disease in humans, the MEF2A gene. Eric earned his Master's in Business Administration from West Liberty University, as well as his Bachelor of Science in Business Administration from Franklin University. In his spare time, Eric enjoys coaching basketball, working out, and spending time with his wife, their 3 children, and 2 dogs. And now we're going to turn it over to Eric.
Thank you, Melissa. Good afternoon, everyone, and welcome to today's webinar being presented by FDA with Packaging. We're going to look at the why, the who, the what, the where, and how. As everyone knows, children are a vulnerable patient population. They lack the autonomy and decision-making capacity to ethically and legally consent to participate in research studies. Sitting across the table on both sides, I've consented a number of pediatric patients as well as adults, as well as I've had my children approached for clinical research studies. One of the things that's most important when you're going through a consent and assent process is really making sure not only the children or adolescents, but also the parent and caregiver truly understand the information to be able to make an informed decision about whether they want to participate in the research or not. Another thing that's really important is just the communication skills and the time that's taken when you're approaching a patient for research. You want to make sure that you're able to address all these questions and that you're able to give adequate time to make the decision for the patient. Being on the other side of the table and having a child in a clinical research study is also important to be able to just understand the information, be comfortable in the settings, and be able to just talk through and make the best possible decision for your child. Why is it so important? Informed consent and assent is not only an ethical requirement, but it's also the law. It's our duty as healthcare providers and parents even to protect the children's rights, safety, and well-being whenever they're involved in any type of clinical research. We want to ensure that the children and their caregivers fully understand and comprehend all the information before they're making a decision. A lot of times this is going to take multiple rounds of questions and answers to gauge how much of the information is being comprehended and retained. And the most important thing is we always want to make sure that the decision is completely voluntary without any coercion. Why do we conduct pediatric clinical research? It's crucial for understanding, furthering the science, and increasing the education for diseases, disorders, and ailments. A really interesting quote that I read not too long ago was actually by the Children in Clinical Studies organization, but 70% of the time when a child is given a medicine, it has only been tested in adults. The medicine is actually approved by the FDA because it's been studied in adults, but it's actually given to children as off-label. When thinking about that, that is why it's so important to really do pediatric research, and that's why the informed consent and assent process is so crucial when they go through the process to recruit patients. Pediatric research is also going to give children cutting-edge therapies. It's going to also allow for earlier detection and diagnosis, as well as contribute to future research that could save lives. Who's involved with the process? I mean, it starts with the patients. It also involves the caregivers, which is the healthcare professionals, as well as sometimes it can involve legal authorized representatives or even wards of the state. One of the largest hurdles facing patients is when they want to enroll in clinical trials is lack of awareness and understanding what they're actually getting involved with. With clinical research studies, there's additional tests, therapies, and changes to standard of care. The patients have the right to have all the information to be able to make an informed decision. In the case of children, though, the children as well as their parents and caregivers have the right, but they also have to be able to get the additional information and make sure it's easily, again, comprehensible and retained. The parents are always going to be looking out for the best interest of the child, and it's really their standard to look at this. You know, they're typically the decision makers whenever it comes to health care with their children, and they have their children's best interest at heart. Some of the things that, you know, when you're thinking about the children's best interest, you really have to make sure that you're not, you know, it's opposed to Big Pharma or the sponsor of the actual clinical research study. The treating physician's interests. A lot of times these physicians are doing different types of research with certain ailments, and they might have a vested interest, whether it's proprietary or financially. And also it's really important that, you know, parents, they have the right to express personal choices and religious beliefs. What we want to make sure is that it's limited in the decision-making process. We want to make sure that they can express, again, these choices and these beliefs, but when it comes down to it, the decision really needs to be in the best interest of the child, especially considering the health care and the medical history of the patient. Who's involved with the process? The healthcare professionals. Again, this is the frontline staff that's conducting the research. The institution is going to have a principal investigator, which would be the physician that's actually conducting the study. And then they're going to have study personnel who would be designated and trained by the principal investigator. You're going to have sub-investigators. These could be clinical research fellows, or these could even be residents that are doing rotations within clinics. It could be clinical research nurses, research coordinators, and a lot of times there can be key personnel as well. They would be designated on the responsibilities log, and also not only study trained, but typically city trained, as well as the institution will have a compliance and research training as well. The healthcare professionals, really, their role is to not only conduct the study, but it's also, again, making sure the best interest of the child as well as the parent or caregiver is sought throughout the process. We want to be able to give respect and listen to parents' view on the child, understand the illness of the child, as well as the proposed treatments that are going to be part of the research study. When possible, the healthcare professional should attempt to accommodate all the parents' wishes. A lot of times clinical trials have very long and taxing schedules of appointments, procedures, and tests. And, you know, it's really hard today to be able to navigate that healthcare scenario for parents. So a lot of times professionals have to really look at the study and see, is this really going to meet the means of the child, be in the best interest, and also not tax the parents. You know, and there are going to be times when you're going to have to involve either a legal or ethics consultation as well when you're going through the process. Who's not in an ideal situation? Parents or caregivers who are overwhelmed. Dealing with illness in a sick child can be extremely stressful. You're trying to make an informed choice for the child. And healthcare is conducted at a breakneck rate these days. There's administrative burdens between all the paperwork and forms that need to be completed. Who doesn't show up to an appointment and not have registration, insurance verification, previous medical history, current con meds? And then you throw on top of it a clinical research trial, which even adds more forms and tests and times to appointments. It's completely complex, and again, you know, if a parent is not going to be compliant with the research study, that's something that the healthcare professionals that are involved with the study, the PI, the research nurses and coordinators, they need to either see if there's services that can help, or they need to see if the patient's going to be truly compliant and a good candidate for the study. Who decides when parents can't This is an interesting case, but there's going to be times where a child's guardian, legal authorized representative, or even in some cases, a ward of the state can bring a child in for a healthcare appointment. When you're thinking about informed consent and assent, you really have to think who is truly the medical power of attorney for this child and who has the best interest. A lot of times, since they're already coming in for clinical care, that'll be clearly documented in the medical record. Depending on states' laws and the individual decision of institutions too, a ward of the state may not be the best candidate to be able to do an informed consent and an assent for a patient because a patient may not have the same rights if they're under state supervision. If the child's in foster care, it can be the same thing. It becomes very complex. If it's not clearly outlined, the healthcare professionals really should involve legal counsel, possibly the IRB, before making any decision with moving forward with a consent and assent for a patient. Who should never be involved in the process? One thing with clinical research is that you're always going to hear coercion and financial interest. It's really the healthcare provider's job, as well as the parents, to understand if there's any type of financial or proprietary interest involved. There should never be a pharmaceutical sales rep or medical device sales rep present during a consent process or at any of the appointments as well. Most healthcare institutions now, they list if there is financial interest with physicians and attendings in the hospital. They should, again, never be involved in the research study if they have financial interest with a company. And then anyone else that could be considered coerced in the decision-making capabilities. What about challenging questions that can arise during the assent and consent process? These types of questions are not easy to navigate. What if the child is an adolescent between 12 and 18 years old and they refuse to do the clinical research? What if they're considered emancipated? And then what about when the parent's in the midst of a legal custody battle and medical power of attorney hasn't yet been established or clearly defined? Which parent really has the true right to consent the patient to a clinical research study if one parent approves of the study and the other doesn't? And then obviously coping with parental preference if it's an aggressive therapy for a gravely ill child or a child that may potentially be dying. Again, these are all challenges that need to be addressed and looped in with a PI and an IRB as well as legal counsel. What is informed consent? Informed consent is not just signing a document. It's a patient's voluntary agreement to actually participate in a clinical research study. For children and adolescents, the process involves not only communication between the actual patient, but also the parents or the caregivers of the health, as well as the healthcare professionals. Some of the core elements of the informed consent, always providing the information. The most important thing is assessing the patient's capacity and understanding of the information, as well as the caregiver's ability to understand and comprehend the information as well. And then ensuring the patient or parent is not being manipulated or coerced throughout the informed consent process. For pediatric decision-making, informed consent becomes parental informed permission combined with the assent of the child or adolescent. The parent is going through and reading the informed consent. They're going through the process and they're listening to the healthcare providers as well as the child. But it's a team effort, and they're going to look at the document. They're going to explain it. There's going to be some visual aids that I talk about in a few slides as well. Parental permission also includes the elements of the informed consent, plus it has to be, again, in the best interest of the child, and it really is to determine what is the best interest. We have to protect the children from any abuse or neglect, and that's embedded into the assent as well as the parental and caregiver decisions. What are the required elements of the informed consent? According to 45 CFR Report 46 and the Common Rule, there's 8 required elements. There's the explanation of research. This would include why the study is being conducted. What are the standard treatment options should be discussed and disclosed as well should the patient decide not to participate. What are the benefits of being in the study? What are the risks? Which could include foreseeable risks as well as discomforts to the patient. Confidentiality. To what extent the confidentiality of the patient records will be maintained throughout the study. This is really important, and with the heightened security breaches, a lot of patients are going to want to make sure they take their time and read through this and understand all of the levels of security that have been put in place for the research. Description of available medical care and compensation should an injury occur from being in the research. And then the statement of voluntariness. Again, making sure the patient knows that it's completely voluntary should they participate or should they not. And then obviously the contact information should they have questions throughout the consent process. According to Subpart D of 45 CFR 46, we want to make sure that children aren't participating unless if it poses a higher risk than just general living. What is assent? Assent is, children aren't able to give true informed consent until they turn 18. So assent is a part of the process that's added. It's when, again, the child is too young to give consent, but they're not old enough to engage in the consent process and understand the research, again, the benefits and the risks. Assent also really looks at the developmental capabilities of the patient. And we're going to go through that in a slide or two about some of the things that talk about the comprehensible capabilities of a child or minor. Assent really is trying to gain the child's cooperation, but also to explain it, all the elements of the trial and how the patient's going to participate. And we also want to make sure that there's rationale for the autonomous decision making. And assent also empowers the child to, I guess, the extent of their development capabilities. Assent should always include the appropriate awareness of the condition. It should talk about the disease or ailment in language that the child would understand, and exactly knowing what to expect with the tests or treatments. Again, this is really important as you're talking with the child and the caregiver to be able to explain the test, even if it's a test they've been through before, like a simple X-ray or a simple blood test. You're going to want to be able to explain it so the patient understands, you know, what are the added things that are being added by them doing the research. And then just, you know, solidifying their willingness. You really want to make sure that the child is willing to be able to do the study and understand it, but you also want to be able to honor that not only the child's decisions, but as well as the parent and the caregiver. What about guidance based on age? This is where it's crucial to really understand the patient population that you're dealing with. When you're going through the consent process, you really want to be able to not only teach the child about the clinical research, but you want to be able to elicit their opinion and be able to communicate and understand what information they're being able to retain. You know, for ages 2 to 5, you can use learning aids, and there's a limited basis for being able to make a decision at this age because of life experience. For ages 6 to 9, this is the age group they're beginning to read and write, and they're being able to understand, and they have limited life experiences that they can reflect on when trying to make decisions. So this is something that goes into consideration when they're putting together the consent form, as well as when you're communicating with the patient, as well as the parent and caregiver. And then obviously adolescents 10 to 18 years of age. National law requires assent at this age group, whether it be verbal or written, because this age group can read and write and comprehend, and they have a broader spectrum of life experience to be able to begin to make informed decisions for themselves. These are just some of the typical questions and consents and points that you want to think about when you go through the assent process. You know, you're going to be provided more information than you would with an adult because you want to make sure that the child understands it. You want to make sure always that the goals of the patient and the parent are being met through the research, but as well as with standard of care. You want to make sure that you're explaining everything, whether if you're using graphs and pictures and images. They're great aids for children going through an assent process, but you want to make sure, too, the parents understand, especially if they're going to take it home and there's a series of appointments they're going to be following for the clinical research study, that they can also go through those learning aids with the child. You always want to make sure it's in a comfortable setting, which I'll talk about in a little bit. You want to continually gauge and speak with the child to see how much they're understanding the process. It doesn't start, again, just with the first visit, but it's throughout the clinical trial that you're going to talk to the patient, the parent and caregiver, make sure they understand the next steps, understand what they've already participated in, and continue to talk about the benefits and the risks. And then you really want to just understand that the situation is extremely challenging for not only the patient, being the child, but also the parent and caregiver. Whenever you go to an appointment now, they're already stressed. You don't feel well. You're there for a reason. When you're adding clinical research to it, it heightens the situation. What's the key difference between assent and informed consent? This is really important, and this is really the basis behind a lot of this talk, is just, what really is informed consent and assent, and how does it play a role within healthcare now? Within informed consent, it's more than just a medical power of attorney and signing a consent. It's making sure that they're willing to participate, they understand everything that's going to go into the clinical trial, and that they have all the necessary information at any time to contact the healthcare provider, the IRB of record to speak about questions. With assent, with assent for clinical research, they're not legally authorized to sign a consent form, but it's more of a process. The assent is usually a shortened version of informed consent with just basic information geared towards the understanding as well as the age of the child. You want to be able to give them the information so that they'll be able to understand it. What are the regulatory requirements? Under Common Rule 45, Part CFR 46, as well as state legislature, and even the FDA, there's codified policies that protect human subjects. It regulates the research involving human subjects in clinical trials of the products that they're actually regulating. Assent's not required by the law. It is required for adolescents, but it's not required to be in writing. It can be verbal or written. A lot of times the IRB of record is going to make the determination if they want a written assent form used in a study or not. To the extent of 45 CFR Part 46.116, there always has to be adequate provisions for an assent for children or adolescents. And again, they make that determination whether they're going to waive a physical assent or not. It depends, again, on the level of risk for the research as well. What about parental permissions? This table, it's a good table to go through whenever you're thinking about research, because again, there is some research that they try to require both parents to be present for the consent process and even sign off on it. If it's minimal risk, typically it's just one parent or the legal guardian that can sign off on the consent form. If it's greater than minimal risk but there's a direct benefit to the patient, it can be one parent. If it's greater than minimal risk, there is no direct benefit to the patient, but yet it's going to obviously gain additional knowledge about the condition for the patient. They may ask both parents or legal guardians to sign the consent form. If second guardian or parent is available, there would be a witness as well. And then obviously greater than minimal risk with no direct benefit, but it may alleviate serious problems or health or welfare in the future. Again, this would be both parents if they're able and present, and if not, at least one parent or legal guardian as well as a witness. There's many forms of learning that go into children's development as well as adults. When you go through the process with healthcare now, there's a lot of different educational aids that are available, and they're incorporated in the consent and assent process for pediatric research. These visual aids can be charts and graphs that can help understand the length of a procedure or a study. Some studies even use cartoons to explain a visit to a patient. In today's age, iPads and smartphone apps are being used more and more and integrated into healthcare education as well as clinical research. This illustration is pretty generic and it's used throughout healthcare. For adults, you can ask them a pain scale between 0 and 10 and they're going to understand you. For a child, it's better for them to have a visual aid where they can actually look and see and be able to make a better assessment of how they truly feel. So again, aids are heavily involved not only in the consent process but also throughout clinical research trials. Where's the best place to conduct informed consent? As everyone knows, clinical space is a premium, and designated clinical research space is almost unheard of anymore. The environment's critical whenever you're consenting a patient. There are additional concerns whenever you're going through the informed consent and assent process with children and adolescents. There needs to be as little distractions as possible since the attention span in children is less than an adult. You want to make sure that it's comfortable, it's private, it's neutral space, and space adequate enough to accommodate family or caregivers. and make sure that, again, it's going to be a place where time isn't going to be a limitation for the consent process. Again, with a shortened attention span, you want to make sure that the child as well as the parent caregiver has more than enough time and they're comfortable to go through, read the materials, listen to all the information, and be allowed enough time to make an informed decision. How to document assent and informed consent. This is really important. Subjects must be able to read and understand the information. So as you're going through and documenting in an EMR, the time and date of the informed consent and the time that the discussion occurred is crucial. As consultants would know, whenever you're looking at an informed consent process in an EMR for audit purposes, you're going to want to make sure that the assent and informed consent were signed before any research was actually instituted or started for the patient. You want to make sure that the patient's name, as well as everyone that was involved with the process, is listed out as well in the EMR. This is your study staff, your family or caregivers, as well as the actual patients themselves. Any questions that were addressed. This is really important because again, it's not just documentation of the consent, it's an assent, but it's the consent and assent process. These questions are going to help the healthcare providers understand how much comprehension and how much communication occurred during the process, as well as a scanned copy of the consent should go in the EMR. Again, if a patient shows up to a different appointment, another part of a hospital, those caregivers need to be able to understand who to contact, what kind of research and therapies and interventions are being provided to the child, so they can navigate and make an informed decision on the care they're going to provide to the child. And then obviously, as much as you can, document confirmation of comprehension. This is where, as a healthcare provider, you're not only asking questions to the patient to see how much they understand, but how much they're retaining. So as you go through the assent and consent process, you want to document not only what the child is asking, but the parent and caregiver. And the informed consent process, again, I know I've weighed on this a couple of times, but it doesn't just happen one time. It's throughout the entire clinical trial. You want to continue to document in the EMR that you did address consent, you did talk about risks and benefits, and that it is voluntary at any time. The patient can withdraw as well. How do you document the process? You want to make sure that it's clearly stated and documented in that medical record. Again, questions are revisited throughout the process and documented at each visit to show that the patient understands, the caregiver understands. If there's new questions, it's important to go back and read through the records and see that the patient, if they're asking the same questions over and over throughout the visits, then obviously there's a knowledge deficit that needs to be addressed for that patient. And then the contact information, again, needs to be provided to the patient, and it needs to be documented in the EMR should they receive care somewhere in another department that's not involved in the clinical research study. Today, these are the references that were used throughout the webinar for my presentation. And at this time, this is an example of what an assent could look like. It's usually one page. It's usually shortened and summarized for a child. Basic information is given, but then all of the conditions, all of the tests and things like that are given in a language and summarized to a point where a patient can understand. And then at the bottom, the patient or child acknowledges, as well as the person that's actually providing the consent. And this would go along with an informed consent. As anybody that's conducted research and done an informed consent can be taxing. It can be anywhere from 15 to 30 pages long. An assent, again, is just a high-level summary at a level that the patient can obviously understand, whether it's a child or adolescent, but it is just usually a one-page document. And at this time, there's time for questions. Thank you.
Okay, before we get started we've had some questions submitted in advance. Thank you to the guys who filled out the Google Forms. And the chat box is open, so if you've thought of something that didn't come to you before, go ahead and feel free to pop on that chat and enter your question in. I'll do a few housekeeping things before we start the questions. Again, the phones are muted. Make that question request there through the chat. After the webinar, we will have a link to request an attendance certificate, but don't worry about that if you don't get it jotted down, because we'll be sending out an email afterwards so you can request that, and we will be giving you a link to a recording. I think we'll go ahead and get started with our first question. Eric, we've had someone submit, what are the differences between assent and consent in clinical research? And this is one that was submitted before the presentation.
Sure. As I went through, the informed consent is actually a legal document. The informed consent, it goes through all aspects of the study, and I discussed those 8 elements in my presentation. Assent, again, it's legally required for children and adolescents, but it's the process. It can be verbal assent that's actually recorded in the electronic medical record, or it can actually be a physical form like I just showed an example a few minutes ago. But it's really just a change in process. Again, the informed consent is a required legal document that has to be signed and acknowledged before any care is ever administered. Assent is part of the process and should just be documented.
Okay, and our next question is, how would a principal investigator check to see if the child or caregiver truly understands the research?
I know I weighed in on this a couple times. Again, it's really important to, throughout the process, throughout the clinical trial, the principal investigator should continue to ask questions to the child and the caregiver. See how much they remember from visit to visit about the clinical trial. See how much they remember about the benefits and the risks. And again, it's so important to make sure that this is documented in the electronic medical record. But it really is just a question and answer form that should happen at every visit. The PI should spend adequate time just talking to the patient, making sure they truly understand it, and then documenting this information in the EMR.
Okay. We've had a new question come in from the chat. From which age can a child sign an informed consent?
They'd have to be the legal age of 18 or over to sign an informed consent. There are some states, though, that have regulations now. If a child is emancipated, and usually they're a teenager, they can sign informed consent. But again, it's dependent on the state legislature.
Okay, we've had another one come up. How do you confirm legal status of a parent? Do you request to see their legal documents, especially if one parent states they have sole custody of the child?
Today, typically what happens is those patients are already being seen for through clinical appointments, at whether it be a doctor's office or a hospital. That's usually confirmed during the registration process for their clinical appointments. If it's not clearly documented, you would want proof of that. You always want to have that information on file. If you don't, then you really shouldn't move forward with the research. But typically nowadays, that is something that is captured and documented during the registration piece for clinical appointments. If it's not, then you should request it. If you're pre-screening the patient and that information is not on file, a lot of times these patients are coming back for multiple clinical appointments. You may approach them and say that you'd like to speak with them about a research study in the future, but you would need proof of medical power of attorney for decision-making purposes.
All right. The next question that was submitted beforehand was, what do you do if a child refuses assent?
Again, this is where the caregiver and the parent are important. A child can refuse. The assent process is really to give them as much information to understand the study as possible, but it is the rights, it is the right and duties of the parents to make the best decision for the child. But the child has the right to refuse, and that's where you need to involve the entire healthcare team. That's where the principal investigator and the parent and the child should make the decision jointly. They should go through and discuss the information and try to make sure that it's agreeable decision, but the parent or caregiver has the ultimate decision with the healthcare provider. If the principal investigator feels like the child's going to be non-compliant with the research and they're not going to be able to go through the research without having issues of not doing tests or not, dropping out early, then at that point it'd be the healthcare provider's decision to whether to proceed with consent with the parents or not. So again, it's a team approach, and the child has the right to refuse at any time. Legally, it's the parent or caregiver that does make the ultimate decision, but the healthcare provider should weigh that in whether they proceed with the research with that patient or not.
Okay, we've got another question from the chat. Is there guidance for what an assent documentation should contain?
Each healthcare institution, their IRB, should have a template that they can use. As far as federal regulations, there isn't. There's just, again, you go back to the 8 required elements of consent, and typically an assent mirrors that: benefits, risks, contact information. The last slide, it's just done at a much higher level, but it would follow the same 8 required elements.
Okay, I've got one more that was submitted beforehand. How would you handle assent and informed consent whenever there is a ward of the state present for the child or adolescent?
The ward of the state at that point is the medical power of attorney for that patient, since they would be the representative. It depends on the circumstance, again, and that's where the IRB and legal counsel would probably want to weigh in. If the patient is under state supervision, say like a detention center or something like that, they may not be the most ideal candidate for research, and they would probably also be giving up their free will since they were a ward of the state. So the state would ultimately make that decision, and they would be the ones making whether they sign off on the consent and move forward with the clinical research for the patient or not.
Okay, we've got another one from the chat. We've seen some language related to respecting dissent as it relates to study-specific activities. Could you explain what this means?
Can you repeat the question? Sorry, Melissa.
Yeah. It said we've seen some language related to respecting dissent as it relates to study-specific activities. Could you explain what that means?
Yeah, again, at any point, that goes back to the assent process. If it's a teenager and they're going through the assent process, and at a point they are part of the decision making, and they can refuse to continue on their research, and the healthcare provider has to respect their wishes. With dissent, again, it's voluntary for them to participate. They have to honor those wishes, but they also have to document what the reasons are that the patient wants to withdraw at that point. And that's, again, the exposure I've had with dissent, it's not been a great deal, so I don't want to answer that ad hocly, but again, I think it would be up to the healthcare provider, but I think adolescents, it applies more with dissent.
Okay, that wraps up all of the pre-submitted questions. I'll give you guys just a second to see if anyone has something else that came to mind that they want to submit through the chat. Okay, well, I think that wraps up today's webinar. I want to thank everybody for taking time out of their Thursday and joining us, and thank you to Eric for that very informative webinar. Again, we will be sending out a link. I know there's another slide here that has the actual website that you can go to the Google form to request an attendance certificate, but we will be sending out a link within a week for you to make that request, and with a link to the recording of today's webinar. On behalf of FDA Quality and Regulatory Consultants, thank you, and we'll see you on the next webinar.